Okay, thank you very much. Hey, good afternoon, and thank you, Dr. Ramaiah, for the opportunity. I'm Youngje, a surgery resident from South Korea, and today I brought a highly instructive case I observed during my rotation in Arizona last year. The patient is a 78-year-old female transferred to us after an emergent EVAR for an infrarenal AAA. She first presented with vague abdominal pain, and abdominal CT was done for evaluation. It showed a 7.9 by 6.5 centimeter aneurysm with hostile neck anatomy. And crucially, bilateral CIA aneurysms were present, leaving no suitable landing zone for standard EVAR. And as you can see on these images, you can see the heavy intraluminal thrombus and in both abdominal aneurysm and both CIAs. And you can also see the right inferior renal artery is accessory inferior renal artery is visible, and the arterial wall alteration is just distal to it. And the left iliac aneurysm landing zone was extremely no, not this is it. Okay, and the left CIA landing zone is extremely short at 7.2 millimeters, and on the right the aneurysm extended entirely to the bifurcation. So, because she was symptomatic with abdominal pain, emergent EVAR was performed on the right without a landing zone, and the internal iliac artery was embolized with a plug and the coils, and the limb was extended to the external. And on the left, the internal iliac preservation was initially intended, but a persistent type 1B endoleg required plug embolization and limb extension to the external. So, resulted in complete bilateral internal iliac exclusion. So you can see the post-EVAR CT, and you may see there's an additional balloon expandable stent graft was inserted and completing the exclusion of both internal iliac arteries. And after the procedure, the patient experienced bilateral buttock pain and a small sacral decubitus wound, but she was discharged on day 4, and at this time, she was fully independent in self-care. But 2 weeks later, she was readmitted with progressive wound enlargement. And despite multimodal care and 5 debridements, the necrosis progressed and is accompanied by some urologic deficits. And she also developed fecal incontinence and eventually required a colostomy. So you can see this clinical photo. It demonstrates the extensive tissue loss across the sacral and the gluteal regions. And this was the situation she was transferred to our institution. So for definite management, we require muscle flap reconstruction. And it also needs some blood flow restoration. So, her right internal iliac was completely occluded by the coils. So we targeted the left internal iliac. And we first considered the surgical bypass from external to internal, but it was deemed to high risk due to a fragile and infected tissue. So we planned an endovascular approach. And the initial angiogram showed absolutely no collateral flow to the internal iliac. So we first tried a laser fenestration to reach out to the internal iliac, but we failed, so proceeded with some retrograde vascularization. Using an angled glide wire and a command wire, we carefully navigated between the pre-inserted stent graft and the native arterial wall, successfully gaining access to the left internal iliac. And we injected 2 milligrams of TPA for pharmacological thrombectomy, followed by mechanical thrombectomy using a penumbra aspiration catheter. As you see, a subsequent angiogram showed a significant restoration of blood flow. And we then completed the revascularization using the sandwich technique. After balloon angioplasty, 2 bivalve stents were deployed into the internal iliac, and kissing balloon angioplasty was performed, and an extension lean was inserted to secure blood flow into the internal iliac. And you can see the final completion angiogram confirms the successful restoration of robust flow to the left internal iliac and its branches. And after the surgery, the patient was stabilized and her buttock pain was improved. And she was transferred to a SNF or continued wound management. But unfortunately, her mental status deteriorated on day 6, and by day 12, she was transferred to a local emergency department, and she was transitioned to a palliative care and expired the following day. We don't know the exact cause of her death, but we assume that her fatal ischemia reperfusion injury is highly suspected. So I think there's a lesson that we can learn from this case. The concomitant iliac aneurysms are pretty common in AAA patients, and it complicates the distal landing zones. In these cases, internal iliac exclusion is often necessary to prevent type 2 endoleaks. But while many patients experience buttock claudication, they generally tolerate bilateral exclusion well. So serious ischemic events like this case are extremely rare. But why is it usually safe? In trauma or obstetric patients requiring bilateral internal iliac ligation, severe ischemia is rare due to a robust collateral network from the femoral and the external iliac arteries. However, AAA patients typically suffer from extensive atherosclerosis, heavily compromising these collateral pathways. So we must recognize that severe pelvic ischemia is a real and devastating possibility in this population. So how do we prevent this? First, a staged approach over 1 to 2 weeks can be considered, but this is not a definitely proven this does not have a definitely proven benefit, but it is often considered a rational and safe strategy. And second, meticulous embolization technique. We must occlude only the proximal main trunk, preserving the distal collateral pathways. And third, the use of an internal iliac branch device significantly reduces ischemic complications. So my point is, severe ischemia should not be left to chance. We must understand the mechanism of pelvic perfusion and actively assess each patient's collateral anatomy during our pre-procedure planning. And if severe ischemia still occurs, a prompt revascularization is critical. Whether through by open bypass or endovascular technique, intervention must be immediate. Delaying the treatment dramatically increases the risk of fatal ischemia reperfusion injury. So if signs of severe ischemia appear, we should evaluate swiftly. So in summary, when facing challenging anatomy requiring internal iliac exclusion, never underestimate the potential for fatal pelvic ischemia. So proactive planning to preserve flow is mandatory, and if severe ischemia develops, revascularize without delay. So this is all I prepared, and thank you for your attention.